Brian Carpenter from Fort Worth, Texas.
And I'm Carl Hasselman from Pittsburgh, Pennsylvania.
You're going to put your drill guide in place, and you can see here it's got feet on two sides. So you're going to set those on the superior and inferior aspects of the metatarsal head. You're going to center this, and you can slide it down just a hair. You can use your crista as a good guide point, or go slightly onto the crista at this point. Now, the important thing is to make sure you don't place this pin in a dorsiflex position. It needs to either be parallel with the metatarsal shaft or slightly more parallel to the floor. So you're going to get it lined up and go straight up the shaft. And this is very important and something that will need to be checked under fluoro for proper positioning.
And so now I'm happy because I'm more down the shaft, and then we'll check a lateral. And so on that one, you can see that we're actually still slightly plantarflex, but I would say in my mind our screw is going to be way within the shaft and safely in an area. Would you accept that?
I would accept that right there.
I would accept that in both directions, because your screw itself really is only going to come to about that level, is where your taper post is going to come to, and you're still well within the cortex of the bone.
So you got a two-step drill bit that's going to prepare you for insertion of your taper post. When inserting this and drilling, you can see here it engages very easy. When it gets down to the second step of the tier, you may want to be a little careful with this because they will jump sometimes and be a little aggressive. So be a little careful. You're going to the second step and come down and just drill till it's flush. You see here that we're flush with the metatarsal head. At this point you can see there's a tap and there's a laser line drawn here on the tap. You're going to take it down till that is flush with your articular surface. And same here, you can see there's a line on your device for this, so it just implants. Again, screw it down till it's flush. And these provide for a very snug, good fit here. And any quarter turn of this will decompress 1 millimeter by inserting it.
Now, this is the measuring device. Basically, you'll notice that the measuring device has a taper on one side, and on the other side is orange coloration. What you'll do is you'll take that post and you'll make sure that it sits inside that post. Then you can take your second device and slides right over top. This has a little footprint on it right here, and that is your mapping footprint. This little device needs to sit onto the articular surface of the metatarsal head. A lot of times you'll only have, in most hallux rigidus, you will have one side that has cartilage left and the other side that's denuded of cartilage, and therefore you really want to be trying to recreate the articular surface. So you'd want to put your mapping foot right onto that articular surface of the metatarsal head, and I usually do it either at 3 or 6 o'clock, depending, or 3 or 9 o'clock, depending upon which side still has good articular cartilage. You'll notice that the orange part actually, there's a line here. You can see it's 0, 1, 2, 3, and then the halves are on this side. And you'll notice that when we look at it, our orange, where our orange and silver meet, it's right at about 2.5. So we have basically a 2.5 shape to the curvature, or the radius of curvature is about 2.5. So at that point, we would just check the other side real quick. Again, we don't really worry about the dorsal side, but the medial and lateral sides. On this side, it's at about 2, but this side is missing some articular cartilage. Therefore, I would go with my other side as a 2.5. So at that point, we would say medial to lateral would be a 2.5. I'm going to hold the phalanx down, and Dr. Carper's going to take that that little foot and place it basically just on the medial and lateral sides of the crista, so the two sesamoidal grooves, both medial and lateral. Here's groove 1 for the sesamoids, and on the other side, plantar surface, you can see groove 2 for the sesamoid is right in here under. So what I'm doing is literally I'm going to place that footprint right into the lateral sesamoidal groove. And then I'll measure, and we can look at it in a minute, but I'm measuring right around 3.5. And on the medial sesamoidal groove, I'm measuring around 2.5, but this side has no articular cartilage left, whereas this side does. And so I would actually say that my 3.5 would be my more appropriate measurement. And so you can see as we were calling out those measurements, we were calling out measurements 2.5, 2, and then 3.5 plantarly. And so dorsally we usually don't care because this is such an abnormal number because of the disease that we're really more focused on medial to lateral and plantar. So we've decided we're going to do the highest of the two numbers is 2.5 by 3.5. So we have an implant that's actually a 2.5 by 3.5 implant. The reamer that we're going to use is a 3.5 because 2.5, 3.5 is the implant. The 3.5 is the higher number. That's the reamer you want to use. We're then going to take our guide wire and place it back into our taper post. Again, tap it to make sure it doesn't come out. We mallet it back into the shaft so they can't move.
Then using the surface reamer, protect your soft tissues is the most important thing here. You don't want to wrap up your soft tissues or destroy the base of the proximal phalanx with this reamer. So make sure you're fairly clear. It will go down until it bottoms out on the previously inserted screw.
Now, one of the things you'll notice Dr. Carpenter did was before he started actually reaming, he was off the bone and started the reamer up. He did not have the reamer touching the bone when he started. These reamers are very aggressive and very sharp. You don't want them grabbing onto the metatarsal head. So you want to start your reamer and have it running before you actually make contact with the metatarsal head. You'll notice that he stopped, and how he knew to stop was he couldn't go any further because the taper post will actually stop you from any forward reaming. And so there's actually our reaming. Before the dorsal reaming, we have the first part of the implant. Now, Dr. Carpenter and I like to actually at this point take a rongeur and actually remove most of the non-essential bone on the dorsal, medial, and lateral sides. It definitely helps with ease of implantation, but at the same time, you're going to be removing a lot of this anyhow. And so we'll take off. You'll notice that he is not touching the plantar surface. He's only touching the dorsal, medial, and lateral surfaces so as not to interfere with our sesamoid articulations. But you'll notice that this device has a post to go into the post, so it's a taper just like your measuring device or your mapping device was. And then at the same time, this part will be attached to the drill. And it actually will come down to ream the dorsal surface for the dorsiflexion implant. It has a stop built into it with this so that you can't over-ream or over-go. You just want to make absolutely sure that you have this post sitting snug. And Dr. Carpenter is going to do that right now.
When you insert this in, like Dr. Hassman said, it's got a taper, so take it down till it's snug. Now, what you need to do on this is check your alignment. Go straight on the dorsal aspect of this. A great landmark to be able to line this up to make sure you're not sitting off on the medial shoulder or the lateral shoulder is look at your crista. And you're wanting to line this straight up in the sagittal plane with the crista. So what you're going to do is find your crista, line it up till it's straight up and down with your crista. You can go ahead and just get it to advance down. Make sure you're sitting exactly where you want to be before you do any kind of drilling. So we're lined up with the crista. What we do is, again, back it up, start it off the bone, take it down. It's not a lot of bone that's resected. It allows for the implant and take it down until it bottoms out. And you see there that it's coming down, getting closer and closer, and it'll come down, and it bottoms out totally. So this allows you to be safe with it, not over drill, but get the appropriate depth. Then you remove it off. So at this stage, I'll take that little lip that's still sitting there and just come around with the rongeur and clean up any soft tissue or anything else that I'm worried about might cause any problems, with the implant. So now you can see that we're sitting with a nice, clean surface across the dorsal aspect.
Now at this point, you'll have a trial. And the trial implant will give us an idea. We use it has two little holes, and Dr. Carpenter will show you the holes, so you can put a suture on it so that you can actually easy to put it on and off, so you can remove it and put it back on. easier. You're going to stick that right into that post, into that taper. Dr. Carpenter, how do you assess them at this point?
See, at this point, you can see it's sitting in position. You can see your motion and the articulation between your phalanx base and the implant. So you can see this person's getting motion, which is greatly improved compared to preoperatively. Now, when you're looking at this, you can see it's smooth, but you want to make sure that you don't have it set in such a way that you got a clicking or anything where you don't have good anatomical alignment with the phalangeal base. So then you can say how much is this is real dorsiflexion, how much is not. Well, you really need to load the foot to see what you have. A great tool and something easy to use is just the case or cover off of a case. You can load the foot, kind of see what you're looking at from a weight-bearing attitude, and then put it through your dorsiflexion and range of motion. You can see here dorsiflexion is coming up on this patient, and we're sitting about 50 degrees here. What I like to do is just like Dr. Hasselman, don't grab this and force it. Take your pinky or something and don't push hard, and just push it up in a nice, easy motion, because people aren't going to walk if this thing is tight and force this thing up. So look at what your motion is at this point. If you need more soft tissue release or other things, there's other things that can be done with it, but this is your basic implant having the trial.
There are different options that you can use to actually release further soft tissues. One of them that's been described is actually taking a gouge. Personally, I use a gouge that's probably twice the width of this, but of the same shape, a McGlamory. You can use an elevator, but what you're going to do is make sure that my gouge goes behind the metatarsal head. So I'm actually sitting, I'll try to rotate just a little bit like that, but you can see my gouge is behind that metatarsal head so that I'm not damaging it. Once I have it there, then I can actually run this up along that entire area. The idea is I'm actually scraping that metatarsal. I'm releasing the plantar plate. And so that would be what I would call one option of a release. And you'll notice that my gouge is actually quite far up in there. I'm basically releasing that plantar plate. Now by just doing that, and then and Dr. Carpenter loads it, you'll see that he gets more motion when we load it. So we've actually improved our motion to maybe 65 degrees instead of 50 degrees.
It's a much smoother range of motion with less tightness already.
And so that's option one for release. The second soft tissue release option, again, is actually going into the proximal phalanx. And what I'll actually do at this point is Dr. Carpenter's protecting the area. You'll notice, just for education first, I'm going to take this freer and show you that we're actually going to go, and I'm going to clean this juice off, but I actually want to release the flexor brevis off of that phalanx, and you'll see the flexor is going to be inserting into this area and all the way around. So if I actually pull this forward, you can get an idea. Here, with me pulling this forward, actually we're going to take the implant down for now, but when I pull this forward, you can see that here is actually the brevis attaching into the base of the phalanx. And so what I'll do is I want to release that. And so I'll actually take a knife and literally just come underneath and release it right off the bone. I'm keeping right on the bone all the way around the proximal phalanx. And you'll notice that as I'm going around, I'm coming pretty far on the medial side. I'm then going to run this knife along, and at this point, I'll switch my knife and my freer just so I can push out on the other side. And now you'll see I'm taking my knife, and I'm literally just running it right along there. I'm staying parallel and against the bone of the proximal phalanx. And I'm literally going to take it down. It's similar to what's been described for a varus ankle and total ankle, where you can take down the entire deltoid, or in a knee, if you have a varus total knee, we've talked about releasing the MCL if it's tight in a varus knee. And so that's all we're doing. We're really just stripping the soft tissues off of it, so that now you can actually see the proximal phalanx. Now, at this point, I would take my gouge. Thanks, Tom. Yeah. And again, my gouge will be wider, but just to verify that I have a good release, I'm actually going to just check all the way around. So I have actually taken down the insertion of the brevis off of the bone itself. The idea is it could scar down in a better position. So here's your phalanx, here's the base of it, your flexor, and I've just taken it down off that whole area. By doing that...
How deep are you going?
Good point. If you look, you can even see it with the lateral now. Here's the phalanx, here's the articular surface of the phalanx, and you can notice how far down I'm going with my gouge. My gouge is going down almost probably a centimeter all the way around. So that you can see we've got a pretty aggressive release here. The interesting thing is just by doing that, we need to put our implant back in. So I can actually put this in now. And people are worried about, am I going to create an imbalance? Remember, you've taken your extensor brevis off the top just by doing this procedure, and now you're releasing the flexor brevis, so it's not like you're going to create an imbalance there, because you'll still have your longus on both top and bottom. But now when I load the toe, I can come up and I can get almost 90 without much force. And I'll actually have Dr. Carpenter do it again, so it doesn't look like I'm lying here or anything.
What we're going to do is load it again, put it on the plate. You can see, really, the same amount of force that was getting us 50 to 60 degrees is now probably getting at least 75 to 80. And with just a slight bit more force, nothing like what we had before, it's able to be taken up to 90.
And the interesting is now we'll take it over to fluoro, because people might be worried, am I just allowing the sesamoids to migrate, okay? Watch what happens to the sesamoids. You'll notice that the sesamoids are still coming up and moving. They're going right up over the implant, okay? So the sesamoids are still moving where they were, and they're sitting down there. So we have not caused retraction of the sesamoids by doing this. No more than you see the deltoid ligament getting into trouble. And we have our trowel sitting, and we can check it again by loading it and see what 2 millimeters of decompression and all those releases have done.
You can see now, even with less force, it's coming all the way up to the dorsal aspect of the implant.
You don't, if anything, I would tell you to avoid a tight toe. A floppy toe is actually better than a toe. No one ever comes back saying that their toe's too loose. They always come back saying their toe's too tight. So if you're nice and loose when you're in the operating room, you'll have a nice report. You have to do the appropriate releases.
With almost no force at all whatsoever, we can get this toe right up to 90 degrees. And you can again see the sesamoids are articulating up onto the implant. They have not drifted or moved, but they're sitting and articulating. And you can see here there's actually the space within the joint. You can see the decompression, and you've created a new joint space for this patient.
Before we put the implant in, we want to address the phalangeal surface. Sometimes, as in this cadaver, most of the phalangeal surface is pretty good. And there's just a little bit of dorsal osteophytes or dorsal spurs. Sometimes it's completely denuded of its articular cartilage. In all situations, the first thing we would want to do is release the spurs on the phalanx. And this reamer actually works very nicely to do that. And what we're going to do is actually take the guide wire, put it right into the center of the metatarsal, but I'm going to angle at about 45 degrees plantar, and I'll show you this on a lateral in a second. And so we have our guide wire in place, and we'll look at it. You can see that it's going down the center of the proximal phalanx on the AP, and then on a lateral, you can see that if this is the surface, we're at about a 45-degree angle. So actually the surface will be like that. You'll notice that the guide wire is at a 45-degree angle. The idea is we can actually remove these dorsal spurs. And so with our reaming, you'll notice that as I'm reaming, we're literally taking off the dorsal aspect of the phalanx. I'm just going to get to that subchondral bone, and I'm going to remove those spurs. So you'll notice that we've basically taken off the dorsal surface, and there's just a small amount of articular surface just in this most inferior aspect of the proximal phalanx. The rest has all been denuded down to good bleeding, basically right down to the subchondral area. I'll take a rongeur and just finish off any extra pieces in this area.
Again, like we've been talking all along, one of the most important things is to make sure it's clear, there's no impingement, no osteophytes, either on the metatarsal head or the phalangeal base. And I think that's something that people have a hard time getting aggressive enough with when they first start doing this implant.
And so you'll notice now with the trowel implant, and as I come up, there's still a nice space between the two as the toe dorsiflexes. And so you're not going to get that impingement of the proximal phalanx. And then I'm going to seat it down onto the post. At this point, you want to do the final Morse seating of the Morse taper. And so you'd actually take your impactive device, you'd hold it here, and you'd want to give it 2 firm blows with a mallet or an acetone or a mallet. And so I would actually personally give it a couple of good taps. Really, it's a Morse taper, so you shouldn't have to hit it hard, but you want to do it firmly. And now we have our implant in place. And so now, with the implant in place, and we've done all of our releases, we're going to check our toe and our motion. And you'll see the sesamoids going down and then coming back up as you move. So each time the toe moves, the sesamoids are still moving, and they're still attached. Even though we've done that release, you'll notice your sesamoids are still moving with your proximal phalanx.
You see how much joint we actually have here with all the soft tissue and all the decompression? You know, you can distract this joint, you can get a fairly large open joint. So you've got a nice loose joint. Like Dr. Hassman said a few minutes ago, just like knees and hips, you don't want them too tight.
And then with an AP on the implant, again, you just want to look at it. Actually, we'll go live floor on dorsiflex, plantarflex, and you'll see how the sesamoids are moving underneath, coming up onto the implant. And so that's exactly what you want when you're done.
Doing this, we've stayed medial to the tendon, so you've got plenty of capsule here to be able to pull this up and close, watching out for any of your neurovascular structures medially. So with this, just either a simple interrupted or a running deep closure with Vicryl, monocryl, whatever makes you happy, PDS, get it closed up and get the capsule totally closed so you recreate your joint environment. Then coming back with the skin, same thing. It's a closure of choice. On the foot here, I wouldn't have a problem using some sort of a running stitch, a interrupted horizontal, or a vertical mattress, whatever is your choice for closure for these patients. To me, the main thing is to get the skin good and closed with a nice, good stitch to really aid you, because what you're looking for with these guys is to be able to get early range of motion.
We've closed the whole toe. I actually like to do a nice compressive dressing. I'll put a lot of 4x4s, pretty aggressive with my padding. I'll put web roll around it. I use an ACE wrap. Some docs like to use a Coban. It doesn't matter. You just want to make sure you have good compression. The other thing I think that is key is after you have done all your, you have your implants in, if you did not use a tourniquet, that's fine. If you use the tourniquet at this stage before I close, I would recommend you put the tourniquet down, make sure you have hemostasis. You don't want a lot of bleeding in here, which will cause a lot of swelling and problems and stiffness afterwards. So I would say that at this point, I have my implant in. Just before I would start closing capsule, I would actually put the tourniquet down, make sure that I have pretty good hemostasis. And then at that point, I would put them in a nice, well-padded splint, a well-padded soft dressing compressive. I put them in a post-op shoe, but I tell them the day after surgery, I want them walking around with just their dressing on. I want them out of the post-op shoe. I make them weight bear in their house, and they're bare just their dressing. I say if you go outside, obviously, you put a shoe on, which would be the post-op shoe I would give them. But I tell them begin moving the big toe, I tell them, I want them moving their big toe the day after surgery. It's on my discharge instructions because I want to get that motion. I don't want to lose it. No different, I tell a lot of people, it's like a total knee, a knee replacement. You want those people moving their knee right away. You want them moving their toe right away. Don't hold them still. I've not had wound complications from moving them early. I know a lot of people worry about that. I think with the compressive dressing, it allows for some motion, but not so much motion that they get wound problems right away. So I'm pretty aggressive with that. Dr. Carpenter?
My dressing and post-op course is exactly the same. I really push them to get out of the shoe in the first 24 to 48 hours because they can think they're walking flat on their foot. We're human. You're always going to use your normal gait pattern and get a little bit more dorsiflexion than you will by wearing a stiff-soled shoe. So I think that's very important. I do the same thing, just a very well-padded compressive dressing. I feel much more comfortable with ACE wrap as well. Make sure we don't get any kind of skin problems as you can get with Coban, even though a lot of guys love the Coban. And most of my patients want to get back in their normal shoe anywhere between 10 and 14, 17 days. I leave the sutures in at least 2 weeks, sometimes closer to 3, depending on how much swelling they're still having, and get them back to normal activities as soon as possible.